Can you hear me?
Yes.
Very good. Okay. So for those of you who don't know me, my name is Robin. I'm one of the R1s here at UBC. And I'm going to be talking about lower GU trauma in the context of the Specialist Trauma Advisory Network BC guidelines that were put out in May on pelvic ring fracture. Before I start, just want to say thank you to Dr. Pierre Guy, who spearheaded these specific guidelines, and also big thank you to Dr. Kavanaugh, who put a huge amount of work into these guidelines from the urology standpoint, and also gave me a lot of help with my slides. So the objective of the talk today is to identify the key management questions for pelvic ring fracture as they relate to urology, and review the AUA East British Orthopedics Association and the BC recommendations on addressing these key management questions. And then towards the end, get into the controversies of primary realignment in urethral injuries relating to pelvic fracture. So to start, just in terms of what STAN-BC is, the Specialist Trauma Advisory Network BC is a specialist advisory and oversight network for complex trauma care across BC. The goal is basically to optimize an approach to trauma care across our province, which obviously spans a number of different health authorities. And from our perspective, from a urology perspective, the aim is to provide a standardized approach so that trauma teams know when to investigate urologic concerns and how to do that, and clarify when we need to be involved. It's important for us to be aware of our local guidelines, these BC guidelines that were just put out in May, so that May of 2019. So that we can support managing these patients based on our local standards. So the clinical practice guideline makes about 67 recommendations in total. 13 of them have implications for urologic management. The parts of the guidelines that are relevant to urology are developed and adapted from the AUA East and British Orthopedics Association guidelines. Like I said, with extensive input from Dr. Kavanaugh. And my goal today is to identify the key management questions that have been put forward, and what the recommendations are from each of the guidelines, and then what the recommendations are in our BC guidelines as well. So the first key management question that comes up is when should urology be involved for patients with pelvic ring fracture? And in order to answer that, we need to talk about what pelvic ring fracture actually is. So the pelvic ring is formed from the sacrum and two innominate bones on either side, which contain the ilium, ischium, and pubis. If you get disruption of this ring, basically, through a fracture, you get instability, and the fractures are typically a result of very high energy blunt trauma. You get bladder injury in anywhere from 3 to about 27% of the cases. And that, what proportion it is depends on how severe the fracture itself is. And you can get urethral injury in about 15% of the cases. Again, that varies depending on how severe the fracture is. And typically the orthopedic management is external or internal pelvic fixation. So in terms of when urology needs to be involved, the AUA doesn't really discuss it. The East guidelines don't discuss it either. And the British Orthopedics Association and the BC guidelines are pretty consistent that in one way or another, there's the potential that urology will need to be involved for all pelvic ring fractures. So if there's any GU injury in the context of a pelvic fracture, urology should be involved. But even if you're not involved, in the kind of immediate hospitalization of the patient, all patients with pelvic ring injury need to have written advice on sexual dysfunction in consultation with urology, and they need to at least have the option to have access to specialized urologic follow-up. And so our local guidelines and the BOAST guidelines really put forward this emphasis on early interdisciplinary management and basically getting a specialist involved early for the best care for the patient. So the second key management question is, how and when should patients with pelvic fracture undergo evaluation of the bladder? Bladder injury should be suspected in kind of basically high energy blunt injuries, so motor vehicle accident, severe abdominal injuries, and signs include presence of gross hematuria, which is present in most bladder injuries. You can get abdominal pain, abdominal distension, bruising, and either a complete inability to void or decreased output of urine. And later on, you can get urinary ascites, ALIA, and increasing in serum levels of BUN and creatinine from reabsorption. In terms of how evaluation of the bladder should be undertaken, it's generally done by cystography. This can either be CT or plain film, depending on the guidelines that you're looking at. With both modalities, the filling is retrograde with contrast to a minimum of 300 cc's or until the patient can no longer tolerate it. If you're doing plain film, there should be a minimum of 2 views at the point of maximal fill and then after the bladder is drained. And there's found to be comparable sensitivity and specificity between CT and plain film cystography, but with a couple of caveats to that I'll discuss in a minute. And there, it is important to note that if there's no Foley catheter in place, the BC imaging guidelines say that you can do passive bladder filling after contrast CT, but this is generally not recommended. And the reason for that is that you can miss things. So you can see here, it does tend to be less sensitive. In image A, there's a patient who is being imaged with passive filling of the bladder. And you actually miss a lot of the contrast extravasation that you then go on to see in images B, C, and D, which are taken with CT cystogram. And so in terms of the various guidelines, for all of these, gross hematuria and pelvic fracture is an absolute indication for cystogram. The AUA also adds that if there is either clinical suspicion for bladder injury or there's microscopic hematuria and high risk pelvic fracture, then those are indications as well. There is variation in which modalities are recommended by the various guidelines. So the EAST guidelines say that it's up to clinician preference if they want CT or plain film. They do note that CT may be less affected for overlying bony fragments, spine boards, and military anti-shock trousers, basically kind of confounders that can be present in these injuries. And the AUA guidelines say basically CT or plain film, clinician preference. The BOAST guidelines are a bit unclear on this. They don't make specific note of either CT or plain film, although at the end of the BOAST guidelines, there is a section on how to do plain film cystography. And there's not a section on how to do CT cystography. And then at BC, basically the universal recommendation is in the setting of pelvic ring fracture, it should be CT cystogram for the reasons that I outlined.
Robin, I'll just interject since you can't necessarily see it from where you're presenting, but there's been a series of chat questions around this, and at VGH, or at least across Vancouver, it's really just CT. I mean, we don't even talk about plain film anymore.
Yeah, I just mentioned on that Robin just included that because the AUA guidelines specifically address plain film static cystogram. So we only use CT cystogram, and that's our recommendation in the STAN guideline as well.
Yeah.
One other thing too is that when you do get a cystogram, make sure they get the post-empty phase, because that's the most important part, because you don't see any posterior, you won't see any posterior ruptures on plain film. You'll see it on CT, but plain film, you need to make sure you empty the bladder.
So moving to the next management question, how should bladder rupture associated with major pelvic injuries be managed? So as we said, bladder injury is often associated with high energy mechanisms. There are frequently the presence of other severe injuries. And injuries can be extraperitoneal, intraperitoneal, or combined. These are typically extraperitoneal in the setting of pelvic ring fracture. And you can have associated urethral injury in anywhere from 5 to 20% of cases, depending on the severity. So for intraperitoneal bladder rupture, these tend to be large blowout type injuries that won't heal on their own. And the typical management is basically immediate repair, with the only exception of that being if the patient is unstable. And without repair, you do risk progressing to peritonitis, sepsis, and death. So there are very high complications if you don't do immediate repair. And all of the guidelines reflect this. So basically, there's been no change to long-standing consensus that operative management is preferred, and this is reflected in the BC guidelines as well. And then just some images here, you can see intraperitoneal bladder rupture on CT, cystography showing contrast extra into the peritoneum and distributing around the bowel loops and the pericolic gutters. And then on the right side, on plain film, you can see free contrast in the abdomen outlining bowel loops or the abdominal viscera. In the setting of extraperitoneal bladder rupture, it's not quite so straightforward. So the general consensus across the guidelines is that extraperitoneal rupture should be repaired at the time of pelvic fixation. Extraperitoneal injury can be managed non-operatively if it's a simple rupture, meaning if it's a single full thickness tear in the bladder wall with urine leakage into the extraperitoneal space. But with any other concomitant bladder injury, that then becomes a complex rupture. So the East guidelines advocate that operative repair should be done if there are complex extraperitoneal injuries, and advocate for follow-up cystography unless it's a simple rupture that's managed operatively. They don't really go into more details beyond this. The BOAST guidelines explain that bladder neck injury needs operative repair, but they don't comment on follow-up cystography. And the AUA guidelines basically take a slightly different approach to what they define as complex. So if there's bone in the bladder lumen, vaginal or rectal lacerations, or bladder neck injury, and those require operative repair and follow-up cystography. And the BC guidelines basically, again, indicate similar to the previous guidelines that operative repair is required at the time of fixation. Non-operative management only if it's simple and there's no fracture repair planned, and follow-up cystography is needed. And then how and when should patients with pelvic ring fracture undergo evaluation of the urethra? And I'm actually just going to stop for a second and look at the chat here. I think there are a couple questions that have popped up. Okay, it looks like that's just kind of some discussion going on about this. So how and when should patients with pelvic ring fracture undergo evaluation of the urethra? So the modality is retrograde urethrogram. This is done by inserting a 12 French or a small Foley, as per the AUA, into the fossa navicularis. And the AUA indicates that you should gently inflate the balloon, injecting about 20 cc's of contrast and taking a pelvic x-ray. The AUA also states that if there's concern later on that you've missed a urethral injury, you can do a paired catheter rug with a small catheter, angiocatheter, in the fossa navicularis around the placed Foley. And generally speaking, rug is not helpful in females because the urethra is quite short, about 4 to 6 centimeters, and there's often the presence of vulvar edema in the context of pelvic injury. And so it's very hard to gain anything meaningful from a rug. So typically in women, diagnosis is made based on physical exam or cystourethroplasty. In terms of what you actually find on imaging, basically you can see any contrast extrab outside the if you see massive extrab without the bladder filling more proximal to it, then the concern is for a complete rupture. Whereas if you get extrab from the urethra, but you can still see some normal urethral continuity, and you can see filling of the bladder more proximally beyond the defect, then that's more indicative of an incomplete or partial rupture. But it is important to note that you can't always distinguish well between complete and partial rupture. In terms of when patients should undergo urethral evaluation, the first thing to note is that in the unstable patient, other life-threatening injuries are going to take priority. So basically, if there are other life-threatening injuries present, then the key is just to establish prompt urinary drainage, however that needs to be done. But if there is time to kind of consider it, then if there's blood at the meatus, the consensus from all of the guidelines is that you should do a rug and then a gentle Foley attempt by an experienced person. It specifies that person should be a doctor in some of the guidelines. And if you do see a urethral defect on rug, but you're successful in passing the Foley, then you call urology early to let them know about it. If you meet resistance, then you should stop right away and call urology. Whereas if there's pelvic fracture and no blood at the meatus, the clinician can do a gentle Foley attempt. If it's successful, great. If not, then, and if it basically doesn't pass, or if it passes but it only drains blood, then you should take the catheter out, you should do a rug. And again, call urology if there's concern for urethral injury. If the urethral Foley can't be passed, then you look at insertion of a suprapubic tube. This can be placed either during emergency laparotomy or percutaneously. And there has been concern mentioned previously about suprapubics, increasing the risk of orthopedic hardware infection, but there actually doesn't seem to be much data to support this. And then finally, looking at the last management question, how should pelvic fracture urethral injuries be managed? So this one isn't quite as straightforward. When we talk about pelvic fracture urethral injuries, we're basically talking about posterior urethral injuries. These can occur in anywhere from 1.5 to 15% of pelvic fractures, with concomitant bladder injuries in about 15%. And again, the percentage you're going to see it in is going to depend on the severity of the injury. The pelvic fracture urethral injuries tend to occur at the bulbomembranous junction because that is the most vulnerable spot for shearing. And you can get either partial or complete rupture. It tends to be more common in men than women. And usually in terms of the degree of force that is required to actually give you a pelvic fracture urethral injury, because of the amount of force, there are often very severe other injuries. So there's a very high mortality rate in these settings, about anywhere from 5 to 33% quoted. And you can see concomitant bladder injuries along with them as well. Some fracture patterns are more likely to result in pelvic fracture urethral injury. So basically, the greater the diastasis of the pubic symphysis, the greater the likelihood of injury. And if you get displacement of the inferior medial pubic bone, then there's also a correlation with a risk of urethral injury. And these can be quite high. This is just an image illustrating basically the mechanism where if you get disruption or fracture of the pelvis, how it can result in shearing or avulsion of the urethra. Clinical signs of urethral injury include bladder meatus, which is kind of the hallmark sign that we think of, but just because there's not blood at the meatus doesn't mean you can actually rule out urethral injury. If there is a complete rupture, you can get inability to void and palpable bladder distension. And if there's partial injury, you can get hematuria and pain with voiding. And as we saw in the clinical management algorithm, you can get resistance to Foley placement. There are also typical signs that have been described, like the high-riding prostate or butterfly perineal hematoma, but these actually aren't always present, and they're often unreliable when they are present. Later on, with the extravasation of urine and blood, you can then go on to get swelling of the scrotum, the penis, and the perineum, or ecchymosis of these structures. So pelvic fracture urethral injuries are rare in women and much less common than in males. Usually this is thought to be because of the shorter length of the female urethra and the increased mobility due to the fact that it's not attached to the pubis. So you can get concomitant bladder or vaginal injury as well with these. And so there is a risk of developing urinary incontinence and urethral vaginal fistula. So even though it's rare, it does have to be kind of at top of mind with these patients. You should suspect urethral injury and pelvic fracture and blood at the vaginal introitus, or if there's a presence of vaginal laceration. If there's hematuria or bleeding for urethra, or if there's vulvar edema. And so generally a vaginal exam is mandatory in women with pelvic ring fracture. and with some of the guidelines stating that you actually need to do a speculum exam. The management of urethral injuries in women with pelvic fracture is generally early repair, with the reason for that being that there are just unacceptably high rates of complication with other approaches. So 59% stricture rate quoted for early realignment, and 31% rate of incontinence for delayed repair, and with early repair really having the best outcomes. It seems like delayed reconstruction can be a problem because the female urethra is just too short to be able to be mobilized during the anastomotic repair, when it becomes kind of embedded up in that scar after a period of time. In terms of the management for men, this is just moved over a bit here. The historical management, basically previously, kind of before we knew how to surgically manage these, pelvic fracture urethral injury was almost always fatal, because you would get urinary outflow obstruction, you'd get extrav, and then progressing to sepsis and death. In the 1920s and 1930s, they first started prescribing primary non-endoscopic realignment. And so they use kind of some of these tools that are shown here, using sound to sound or finger to sound to finger methods, sometimes called railroading with the sound to sound method. They were a big improvement basically on what had been done before, which was nothing. But these have kind of fallen out of favor. And so really at this stage, our management options here are, you can look at management options in terms of immediate, early, or delayed. And the current accepted standard of care is suprapubic tube and delayed urethroplasty. But more and more, there's a discussion about the role of endoscopic primary realignment. And so the primary endoscopic realignment can be done with one cystoscope placed in, hang on, I'm getting chat here.
Roman, I think you should just ignore the chat, and maybe someone can summarize the chat for you. I don't think you have to stop and read it all.
Yeah, I can hit the chat here. So basically, a couple questions relating to: do you do a retrograde urethrogram or attempt a gentle Foley? So the Foley insertion with blood at the meatus is contraindicated. So we should either do a retrograde urethrogram or proceed with cystoscopy in that situation. Blind Foley passage with a high suspicion of urethral injury isn't advised. And it's not so much that the catheter itself causes a huge amount of trauma, but inflation of the balloon with a catheter that has been misplaced is likely to cause quite a lot of trauma. So much better to just understand what we're dealing with. I think you can probably move on.
Yeah, a lot of these can be discussed at the end of the rounds as well.
Okay, so coming back to primary endoscopic realignment, basically this can be done with either antegrade or retrograde cystoscopy or a combination. And so you can get a situation like this where you've got a wire passed through the antegrade scope and grasped by the retrograde scope, and then using that wire to pass a catheter over top, which is then left in place. And so the role of this is kind of still under heavy debate. So this is a study by Elshout that was published in 2017 that looks at outcomes of early endoscopic realignment versus the standard of suprapubic cystotomy and delayed urethroplasty. It looked at 6 non-randomized comparative studies and 7 non-comparative studies that examined early endoscopic realignment. And it reported a stricture rate of about 49% in patients who underwent early realignment compared to 100% of patients who had suprapubic tube placed. So that was basically a stricture of 100% before delayed urethroplasty, and then 10 to 40% following the delayed urethroplasty. Of the patients who underwent early realignment, of the 49% that strictured, about half went on to then have endoscopic procedures, and 40% went on to have delayed repair. And so one of the major conclusions from this was early endoscopic realignment may actually prevent a number of people from needing urethroplasty down the road if they're able to heal without stricture. But unfortunately, there were too many confounders in the study to actually identify who was most likely to stricture and need to go on to the delayed urethroplasty and who was most likely to benefit.
Do you mind if I just interject something there, Robin? Just on that study. So just to put this in context, there's sort of two different schools of thought on how to manage. One is just place a suprapubic catheter, allow that stricture to form. It matures, and a few months after the injury, you bring that patient back to the OR. It's a relatively simple urethroplasty, a very distinct scar, and no other surrounding injuries. And that's my preferred approach rather than doing extensive realignment. The realignment may give you this initial continuity of the urethra, but at the risk of disrupting tissue that would have healed. Also, although we realign a lot of urethras and they leave hospital voiding, many of those patients require further follow-up endoscopic procedures, and Robin will allude to that in some of her other studies here.
Yeah, thank you. So this was a study from the Arab Journal of Urology published in 2015, and it basically reviewed 29 different studies that had been done over the course of about 25 years on primary endoscopic realignment and suprapubic tube and delayed repair, and the as well as early open repair, but really we were looking at endoscopic repair. And so, endoscopic realignment rather. And they reported a stricture rate of about 44% for patients with early endoscopic realignment. So similar to that of the previous study. And notably here, they reported there was no difference in rates of erectile dysfunction or rates of incontinence. And so the conclusion was that erectile dysfunction and incontinence may be a result of the pelvic fracture itself and the injuries rather than the technique used to actually manage the urethral injury. This study by Johnsen and al. Looked at 122 posterior urethroplasties after pelvic fracture urethral injury. And reported that there was no difference in overall success between early endoscopic realignment and patients who underwent suprapubic and delayed urethroplasty. And they defined success as patients who did not require repeat intervention during follow-up. But they did identify a couple of factors that were likely to be associated with increased risk of failure, and those included angioembolization at the time of trauma and basically a larger length of the defect. And then finally, this was a study that looked at unintended negative consequences of primary endoscopic realignment for men with pelvic fracture urethral injuries, and it compared again, suprapubic and delayed urethroplasty versus primary endoscopic realignment and patients who went on to need delayed urethroplasty. And they actually found that in the suprapubic group, the mean time to resolution of the stenosis was only about 7 months, whereas for patients who needed delayed urethroplasty after primary realignment, the mean time was 122 months, and the p-value here was less than 0.01. And in addition, the primary realignment group needed a median of 4 endoscopic urethral interventions after the initial one. And so the conclusion here was that if you've got patients treated with primary realignment and they do actually end up stricturing, then unfortunately there's a risk that they will have more complex strictures and there may be a longer time to resolution. So to summarize the debate, there are basically trade-offs between primary realignment and the decision to not primarily realign, because we've seen from the literature that primary realignment might decrease the number of patients who then go on to have delayed urethroplasty by more than half. But if you are one of those unlucky patients who then needs further intervention after primary realignment, your stricture is more likely to be complex, require multiple interventions, and ultimately may take longer to actually resolve. And so I think that where the literature is lacking here is who the best patients are for selection into primary realignment or not. So, you know, questions have been raised. Is it better to do primary realignment in partial rather than complete injury? Does the length of defect matter? Are there other injuries present? And do things like angioembolization, we've seen they may make a difference, but in the context of all these other factors, we don't know how that plays in. So all the guidelines kind of acknowledge the controversy in the literature. The AUA, actually across the board, they're saying the general standard of care is placement of suprapubic tube and then delayed urethroplasty 3 months later in the majority of cases. The AUA says you can perform primary realignment in stable patients, but this shouldn't be done during fracture surgery because the anatomy of the urethra and the injury will change with pelvic fixation, and that prolonged attempt should be avoided. The BOAST says something similar with their indications for primary immediate repair. They add those in the presence of anal rectal injury, perineal degloving, bladder neck injury, displacement of the bladder, and penetrating trauma to the anterior urethra. And the BC guidelines say that you can perform primary realignment in stable patients, but that really it should be a single, simple attempt. If you're having problems, you should stop earlier rather than later, get out and place the suprapubic instead of trying multiple times, because basically prolonged attempts lead to increased risk of stricture, disrupting the tissue, and increased rates of urine extrav and abscess. And so it's 7:57, so hopefully I've given everybody an understanding of what our local guidelines are, how they relate to urologic injury and pelvic ring fracture, how they address some of the key management questions identified for clinicians who have to manage pelvic ring fracture, both in the trauma bay and then moving forward as they continue to manage these patients. So that's it.
Okay. Well, thanks, Robin. I'll just editorialize a bit. I mean, I was reflecting back to when I was a resident in the 80s, and I would say that we would have the exact same set of slides. I mean, it just it hasn't changed that much. I mean, there was all of the same debate. Do you primary realign in the appropriate patient, right? I mean, you don't fit a square peg in the round hole, and all these patients are so different because of the type of trauma and injuries are different, and the ability to realign easily or not is so individualized. But again, the questions have remained the same. So I'm just looking at any of the chat questions, but if anybody has any questions, please just pipe in right now for Robin.
Yeah,
Robin, I was interested in your comment not to do a primary repair at the time of pelvic fracture repair, which is almost always the time that we would consider doing it.
Yeah.
If the pelvis, I mean, usually they would fix the pelvis first. And could you not then do it in the same OR after they fix the pelvis, or would that still be a bad idea?
So just to clarify, your question is, like, what is the timing for this?
Yeah, in one of your guidelines in your second to last slide there, I thought it said do not attempt a primary repair during fracture surgery, the top one there, the AUA.
Yeah, so I think that what they're getting at there is that during the actual fixation, there is, with the fixation, you can get changes in the anatomy of the urethra. And so when we're looking at primary realignment, it's within the first 48 hours, but it seems to generally be recommended that that's done kind of once the pelvis has been fixed, if it's going to be fixed, and then it's done by kind of like a dedicated urology OR. And I imagine that could be, you know, either right after the pelvic fixation, kind of like in the same OR time, but not happening concurrently with the bladder fixation, or sorry, with the pelvic fixation.
So just one thing to add to that, Peter. So with a displaced fracture, you're less likely to get primary realignment. So the point that they were trying to make in that paper was if you can primary realign after the displaced fracture has been realigned, your success will increase. So the challenge that we run into there is that sometimes patients are brought to the operating room. They have a displaced fracture, but they need to have a catheter because they're going to have a prolonged OR. So do you attempt to realign them to get the catheter in, or do you go to direct suprapubic and then at the end of the procedure, when they've reduced the fracture, attempt to realign? And I mean, the practice is clear. Like, we're going to try to put a scope in and get the catheter, even if our success rate is low. But if you couldn't get that catheter, it's worthwhile to try after reducing that fracture, as long as you can do a gentle attempt at primary realignment.
Okay.
The people that turn sour, in my opinion, are the ones where we have prolonged attempts to realign using two scopes or two sounds. Those are the ones we should try to avoid as a group. And one interesting point that I don't think is substantiated in literature is that my personal success in primary realignment increases substantially with the use of a rigid scope over a flexible. And I think it just gives you a better shot at straightening out the anatomy when you've got the flow of a rigid scope as well as the rigidity.
Good. Any other questions? It is now after 8, but if there's any other questions, please fire away. Otherwise, thank you, Robin. Thank you, Alex, for revisiting this. I guess my one question to the group is, how often is urology now called in with primary trauma, given that it's a, you know, recognize that you've got a bladder injury, urethral injury? Are you called in right away for this, or is the initial trauma team making decisions on conservative versus intervention?
Most of the time, we get called if there's blood at the meatus, or if there's difficulty placing a catheter. Those patients are often, they have an attempted catheter at external locations. They arrive without a catheter, and they need to get suprapubic access. But our overall trauma burden for pelvic trauma is pretty low at VGH. We have maybe 6 PFUIs a year, something like that.
Okay.
a lot seem to go to RCH.
Okay, Miles wins the day for parsimonious answers. He says, we decide. Everyone stays away from making catheter decisions. So that's the chat message from Miles to everybody. Okay, thanks everybody. Thanks, Robin.
Thank you, Robin.
And next week we have Kat giving us a set around. So see you all again next week.